Hello, hi everyone. This is a lecture for the class of 2024, and the topic of today's lecture is trying appointment and speech considerations in complete denture. So, we'll be talking about the wax trying of complete dentures prior to the final acrylization and the denture insertion in the patient. The learning objectives expected are you should be able to outline the sequence in the trial procedure. You should be able to analyze the retention stability and the support of trial dentures. You should also be able to verify the jaw relation records by different method. That is, usually you need to verify whether the centric is accurate with the teeth setting that you have done, whether the vertical jaw relationship, that is vertical dimension of occlusion, is correct or not. And you should also discuss the importance of speech in denture fabrication. That is, the patient's speech phonetics should not be impeded by your teeth arrangement. Denture trying is the preliminary insertion of complete denture wax up to determine the fit aesthetic maxillomandibular relationship. A trial denture is a preliminary alignment of denture teeth that has been prepared for placement into the patient's mouth to evaluate the aesthetic and the maxillomandibular relationship. So basically, trial insertion or the denture trial is basically something like you would do for a suit or a dress. You give your measurements to the tailor, and before the final stitching is done, he will give you a trial of the suit or the dress which you intend to wear for a special occasion to check whether all the measurements are accurate, whether the fit is accurate and to your liking. And then once you are satisfied, he will finish the suit or the dress. So, what is the importance of denture trial? It is a last opportunity to evaluate many previous steps like your jaw relationship, like your secondary impression. All these things are re-verified during this trial denture insertion step. It offers an excellent opportunity for the patient education and facilitate the patient acceptance of the finished processes. So this is a good opportunity to let the patient know what to expect from the denture, what are his expectations from the current trial setup that you have given him, and what he needs to do to take care of this denture, and what is needs to be done to be rehabilitated at the earliest with these dentures before the final process is finished. So it is more like a two-way communication between the dentist and the patient, and once both are satisfied, the denture can be finalized and the acrylization and finishing of the denture can begin. The objective is to verify the centric relationship, centric occlusion, that they coincide, there is no slide in centric, there is no open bite. You need to verify with the tooth selection, that is the selection of the tooth mold that you have selected for the patient, and the teeth arrangement is offers proper aesthetic lip support, cheek support, labial fullness, buccal fullness, all these things, and also to make additional interocclusal maxillomandibular record if you feel that there is an error in the centric or the vertical jaw relationship. Coming to the insertion of the complete denture itself, so as I mentioned, this is like a dress rehearsal or the dress trial, like in a company theater. The three aspects that need to be considered is the function as well as aesthetic acceptability of the denture by the patient as well as the dentist. The competency of the technical delivery, that is the technician's role, that is technician's skill, is also verified here at this step, whether any error has been done by the laboratory if the denture was sent to a third party lab for the fabrication. Various aspects are: first, we examine the denture extraorally, that is the trial denture or the wax setup of the denture is examined before placement in the patient's mouth. And the next is the intraoral examination of the trial dentures, that is, you verify the aesthetics, you verify the periphery borders of the denture, you verify the centric relationship, centric occlusion, you verify the vertical dimension of occlusion and rest, and finally you also verify the phonetics, that is the patient's speech is not impeded, because remember, many of the patients who come to you for denture insertion are belong to a profession where they are active speaker, they may be active social activist, they may be a imam of a masjid, or they may be a pastor, or they may be a priest, or they may also be teachers or headmasters and principals. So speech is one of the very important reasons for which many patients come to you to seek the complete denture treatment. So it is very vital that your teeth arrangement or the teeth setup does not impede with the patient's pronunciation. The extraorally, you examine the denture flanges for the fullness, you examine the finishing of the wax setup of the denture teeth. There should be no wax on the teeth. It should resemble like a final setup that needs to be acrylized and finished. You need to verify whether there are any wax or any dirt or debris underneath the denture, whether there are any sharp edges that may hurt the patient to make him uncomfortable. All these things, and the proper sculpting of the wax that is proper, whether there is it is smooth, whether it the cameo surface and the intaglio surface meet over each other smoothly. It should meet like a fish belly. Next, coming to the intraoral examination. Intraoral examination, first is you need to disinfect the dentures with a proper disinfectant like formaldehyde or glutaraldehyde, and 10 minutes, or with spirit. You need to wash the dentures with soap and water before inserting in the patient's mouth. First, the mandibular denture is inserted, and then the mandibular denture is checked for various things like the peripheral border seal, the level of the occlusal plane, the lip fullness, the relief for the lingual frenum, and the space for the tongue. All these things are changed. Then the upper denture is inserted, and then similarly upper denture is corrected, checked for all these things like the peripheral extensions, the retention, the stability of the denture. All these things are verified in the maxillary denture. Then finally you verify your jaw relationship, whether it was recorded accurately, by verifying the centric relationship, by verifying the vertical dimension of occlusion, vertical dimension of rest, the Silverman's closest speaking space, all these things. And you verify the occlusal plane, whether the occlusal plane is parallel to the interpupillary line, to the alatragal line, whether the occlusal plane is canted towards one side, or whether there is excessive display of the teeth and the gums. So all these things in a nutshell are checked in the examination. So first, as I mentioned, you insert the lower denture, you check for the peripheral borders seal, and you check for the any underextension or the overextension of the denture flanges, which may indicate error in recording the secondary impression bottom molding. Then you check for the level of the occlusal plane. Then you check for the space for the tongue. Like here you can see there is the teeth are arranged in such a way that the tongue is large and there is not enough room for the tongue to lie between the uh, mandibular teeth arrangement. This will create instability. Then you also have to check for the alveolingual sulcus, whether it has been properly, the denture extensions are such that they do not cause the dislodgement or displacement of the denture. You have to check for the lingual frenum relief, especially here in Penang area, as we know that what I have seen in the past 2 months is that most of the patients have very high frenum attachment, or something which is similar to a tongue tie. So you have to give extensive lingual frenum relief for the stability of the denture. Next is we insert the upper denture. We similarly check the upper denture for the peripheral border seals. You should be able to see the mucobuccal reflection. That is the mucosal fold or the mucosal reflection from the vestibule should be visible. It should not be that the denture is pushing against the vestibular or the sulcus, and you are not able to see the movable and the attached gingiva. So the mucobuccal fold has to be visible just above the denture border. All the proper frenum reliefs like the buccal frenum and the label frenum relief should be given at this step, trial denture step, so that you show that the peripheral and the relieving structures have been properly, accurately recorded in the previous step. And of course, you also check for the aesthetics such as fullness, label fullness, all these things. And after peripheral extensions, you check for the retention. As I mentioned, as in previous lectures, retention is the ability of the prosthesis to resist displacement in a vertical direction towards the gravity. So we try to pull the denture down by holding it in a pinch grab between the thumb and the fingers, and you hold your fingers over the incisal edges of the anterior teeth, and you try to pull the denture to check whether the denture is retentive or not. Then the next thing you check is the retention of the posterior palatal seal or the postdam area in the terminal part of the maxillary denture. So this is done by placing your index finger on the palatal surface of the maxillary central incisor and trying to tip the denture. So if the denture tips very easily, that means either your denture is overextended or your postdam area it does not provide proper seal. So that has to be addressed and corrected. Then you put your index finger on the canine, and then you try to tip the denture towards that side. to check whether the hamular notches and the coronoid process have been properly recorded and there is proper retention in that area, that is on the opposite side. If you tip the canine towards the right side, then on the left contralateral side, the tegomandibular raphe, the hamular notch should have been recorded properly and the denture extraction should be accurate. Next, you come to the stability. To evaluate the stability of the lower denture, you place either finger on both the sides of the on the posterior teeth and try to tip the denture. That is, you lift one finger, press with one finger, then place the other finger down, lift the other finger, and you check that whether denture rocks or lifts or tips. So this could indicate again either a poor record base or distorted base plate or the light cued record base, or it could also be that the posterior teeth are arranged to buckle to the ridge, resulting in the instability of the disc. So then you have to arrange the teeth properly on the crest of the ridge. Okay, and then you check for the tongue space. Also, as I mentioned, tongue space is very important in stability of the denture. If the tongue space is not passively provided, then it will result in the instability or displacement of the lower denture. So the proper tongue space should be provided. The level of the occlusal plane should be just below the lateral border of the tongue. It should not be at the level of the tongue at rest. It should be below the lateral border of the tongue at rest. And you should make sure that many times what happens is when you have a smaller maxilla, in order to get a proper class 1 teeth arrangement, you try to arrange the mandibular teeth posteriors in such a way that they are lingually tipped. This result in the constriction of the tongue space, so this has to be avoided and it will create something like this. So as you know, I mentioned in the previous lecture, this is called as a pound line. That is a line extending from the lingual border of the retromolar pad to the mesial line angle of the canine. So on this line, the denture teeth should not encroach, but they should be arranged on the crest of the ridge. If you need to do a crossbite teeth arrangement, you can do a crossbite teeth arrangement for the posterior, but you cannot arrange the teeth in such a way that they encroach upon the pound line and finally they encroach upon the tongue space, resulting in instability of the lower denture. So, as I mentioned, height of the occlusal plane should be just below the lateral border of the tongue and not above the tongue. This will result in instability of the denture, and ultimately it will also affect the retention of the lower denture. Next, coming to the verification of the jaw relationship records. That is, you need to verify the occlusal relationship, you need to verify the vertical jaw relationship, the centric or horizontal jaw relationship. So all these things are evaluated. This says there should be proper maximum interscussion of the upper and lower teeth in the what you call centric relation. That is, centric occlusion and centric relationship should coincide with each other. There should be not be any slide. That is, when the patient closes, there should be maximum intercuspation. That is, the class 1 occlusal relationship should be visible, and there should be no evidence of patient sliding the mandible from the centric position. Creates this will create instability in the denture in the future. So you will check for the centric relationship, you will check for the proper intercuspation of all the teeth in centric relationship. If there are any errors, then you will take an interocclusal record, and the mounting needs to be re-articulated on the articulator. Then you will correct the teeth arrangement, that is the occlusal relationship, and then you will finalize the denture. So you will check for the incisal plane, you will check for the occlusal plane, you will check for the plane of the mandibular teeth. All these things are verified along with the centric relation. So say this is a scenario where patient bites in centric maximum intercuspation, that is in centric relationship. But when you see the centric occlusion, you see that there is the posterior open bite. The teeth are not. This could be due to error in the secondary impression. This could also be due to an error, most likely during jaw relationship step. That is, maybe the heels of the denture were touching prematurely before the wax rims may came in contact, or the patient did not give a proper centric relationship, or the record bases were faulty and distorted. This could result in something like this. Also, if there is error in centric relationship, the midline generally shifts to one side after the patient closes, and then suddenly the jaw deviates to one side and the midline does not match. So this will give you an idea that there was an error in the recording of centric relationship. So this needs to be corrected by taking new intraocclusal record between the upper and lower teeth, or in this case, when there's an open bite, you can put softened wax here between the teeth, and you take a record of the of that side, and then you re-articulate the upper and lower teeth setting with the models. But for this, you have to make sure that the record bases are stable. Otherwise, you will again keep getting errors. Then you have also to check for the vertical jaw relationship. That is, a vertical dimension of occlusion is proper on both the side. That is, in the right and left working side. So you place mylar strips or occlusal shim stock on the articulating paper between the teeth on premolars and molars on each side, and you pull it to see whether the teeth are in proper contact or not, whether there is occlusal prematurities or whether the teeth are out of occlusion. Many times the teeth may appear from the outside to be occluding with each other because of saliva and all these things, but they may not be in contact, and later patient may complain that instability of denture or inability to chew soft food on that side. So both the side you should have similar uh, pressure of the occlusal contact. So this can be checked with the articulating paper or a shim stock. Next, after this, you have to check after horizontal and vertical jaw relationship record verification. You should also check the post-dam area. This is very important. Post-dam area, usually you will check and verify at the time of the secondary impression. You using a T-burnisher, you will palpate the posterior palatal seal post-dam area, and you will identify the anterior vibrating line, the posterior vibrating line, and the soft tissues, palpable soft tissues of the hard and the soft palate in this area. They are marked on the impression, and this transferred to the final master cast. And what many do is we can scrape this area to a depth of about zero point 0.5 to 1 mm, that is from the pterygomandibular notch on one side to the other side, or we can simply create a post-dam seal by creating a simple groove in the post-dam area. So this groove will be filled by acrylic on the internal surface of the denture, that is integral surface of the denture. It will provide a positive pressure in the posterior parietal seal area and give a peripheral seal to your denture. This will improve the retention of the denture, or in some cases when the retention is not there, it will provide retention. So this is an important thing to check and to be incorporated in the final denture before the acrylization. Then you also need to check for aesthetics, that is proper labial fullness, proper, you should see whether the nasolabial fold is being obliterated or not. You should check for the proper cheek fullness. All these things need to be logged. Then you have to check for the incisal visibility in case of the upper denture. In older individuals, usually there will be only about zero point 0.5 to 1 mm of the incisal display of the upper anterior teeth. In some cases, there will be no display of the upper anterior teeth. Instead, you will have display of the low 1 to 2 mm of the lower anterior teeth. This is because of the loss of support of the musculature and the sagging of the facial muscles and the fascia of the face. So, whereas in younger individuals or patients, say patients in their 40s who come for seeking denture treatment, in those cases, you should have at least 3 to 4 mm of incisal visibility. So all these things also need to be verified during the try-in appointment. After all, technicalities are not something which the patient is aware of. For as far as he is concerned, he just mainly looks for aesthetics and function. So next is speech consideration, that is phonetics. So phonetics is used to evaluate whether the position of the denture teeth and the contours of the maxillary palatal vault of the denture base are proper or not, because these will affect the various sounds like sibilants, linguodental sound, labiodentals sound, bilabial sounds, all these things. So first we check for sibilants. This is very easy. Sibilants are basically, you should remember, S for sibilant. So any words that begin with S, that is when the upper and lower teeth come very near each other, that is the silverman's closest speaking space. So like when the patient says S, so this results in the escape of air from between the palatal vault and the superior border or superior surface of the tongue, resulting in the pronunciation of S. So this is only possible when you have proper uh, minimum occlusal space between the occluding surface of the upper and lower teeth. If this is obliterated, then patient cannot pronounce S properly. So you have to check for this. Then you have to check for labiodental sound. As I told you, labiodental sounds are sound which are made by the contact of the maxillary teeth with the lower lip, vermilion border of the lower lip. So if a patient is like words which include F or V, like fly or vault or all these, any words which has F or V in it, you need to verify whether patient is able to pronounce these words properly. If the maxillary anterior teeth are set too apically or too lingually or too palatally, then the patient will not able to pronounce F and V. So this will help you determine whether your upper anterior teeth arrangement is proper or not. And then bilabial sounds such as P for Papa, B for Bombay. So these sounds, if the patient is unable to make them, this means that the upper and lower maxillary and the mandibular anterior teeth are set too far labially, or the vertical dimension is increased. So in that case, either if the vertical dimension is increased, you will need to reduce the vertical dimension, that is by taking new maxillomandibular records, or if the upper and lower anterior teeth are set too far labially, then you will need to intrude them. So as patient is able to pronounce the bilabial sounds such as Papa, Bombay, all these things. So these are very important. So this is a table which shows basically what I told you just now. Like if patient has difficulty in pronouncing linguodental sounds or labiodental sounds, or what do you call sibilants, or all these things, then you know what is the problem. And also you have to check for clicking of the teeth. If clicking of the teeth is there, that means the vertical dimension is increased, and or there is the denture are loose. While speaking, the denture slowly comes down, and the clicking of the teeth is heard. So all these things need to be verified beforehand at the trying appointment, before the finalization of the denture processes. So this more or less brings us to the end of this lecture. Trying is an important step in CD fabrication. Many times we neglect it because as soon as we put a dentures in the mouth and the patient is happy, we think our work is done, and we just tell him to bite, and we see okay, occlusion seems fine. The key of occlusion, we check the of the first molars, and that's it. But if later on at the time or after the denture insertion, that is the review appointment, you get to hear different things like patient is unable to chew soft food, or the patient is unable to chew rice, or when the patient chews on one side, the denture lifts from the other side, or the patient has gagging or the loss of retention due to the poor postdimary or the poor retention, or patient complains of pain in the peripheries of the denture because of the overextended flanges, or obliteration of the relieving and limiting structures. So all these things can be avoided by a proper thorough checkup during the trying appointment, and adjusting and correcting those steps at that time, instead of having to fabricate a new denture, or to reline, or rebase the denture, or to again remove the teeth and do a new setup on the new denture which you have just delivered. So I hope you got to take away some notes from this lecture. And basically, it is not a very big step. If the jaw relationship records are done properly, you will should not face any problem during the try-in insertion. And that's all for today.